Hello everybody and welcome to this video lecture presentation on oral physiologic pigmentation in the E-class. For the purpose of this lecture, I will be referring to oral physiologic pigmentation simply as OPP, just to make things a little bit easier on my side. OPP is quite a very common phenomenon observed especially in dark-skinned individuals and has a wide range of variation in clinical pattern from one person to the other. These variations are mostly genetically determined but overall pose no threat to the individual, hence the nomenclature physiologic pigmentation. In today's class, the lecture outline will emphasize the pathophysiological and management aspects of these benign pigmentations. We will also briefly mention some important differential diagnosis later on down the line. Let's commence with the clinical image of OPP just to orient and familiarize ourselves with the appearance and overall morphology moving forward. The uniformly diffuse band of dark coloration on the vermilion and inner aspect of the lip is a form of physiologic pigmentation as observed in this middle-aged female. The band involves both the upper and lower lips and connects at the oral commissures so that effectively a continuous ring of pigmentation is formed at the entrance of the oral cavity. In this case, other anatomical aspects like the gingivae have been spared. Overall, the pigmentation has a macular characteristic and is completely asymptomatic. Like I mentioned previously, dark-skinned individuals are mostly affected by OPPs, and this person in particular hails from the sub-Saharan African region. OPPs are highly influenced by ethnicity and so has also been referred to as racial or ethnic pigmentation. Even though it may show up during the early years of life during infancy, the intensity increases with age and reaches peak coloration at around pubertal and post-pubertal years. This is because the pigmentations are indeed also positively influenced by hormonal factors, and we will briefly see later on how this is orchestrated at the cellular level. Here is one case involving the lips and gingivae in a young West African boy of pre-pubertal age. Although I have shown you two cases of lip involvement, that is this one here and then now this one, overall lip OPPs are not as common as gingival OPPs. In fact, pigmentation of the gingivae is the most common form of oral physiologic pigmentation. This is the gingival appearance of the same West African boy, demonstrating an intense darkening of the attached gingival tissues. Two features here that suggest physiologic over pathologic pigmentation are, firstly, the marked symmetrical distribution, that is the right side similar to the left side, and then the upper arch being a mirror image of the lower arch. Secondly, the pigmentation is confined to the attached gingiva and doesn't go beyond the mucogingival limits. Occasionally, you may also find out that the marginal or free gingiva is unaffected, but in this case, the coloration extends to involve most of this as well. A third and equally important feature that may also suggest a physiologic pigmentation over a pathologic one is that, in most instances of OPPs, the normal surface tissue architecture and contours are preserved. For example, OPP does not affect gingival stippling or gingival collect morphology. Unless there is a concomitantly occurring disease, the gums in OPP maintain their knife-edge slopes as you move coronally away from the mucogingival line. An interesting observation is that this young chap had a diffuse palatal pigmentation as well. So by now, you can kind of appreciate the trends, variations, and differences in clinical morphologies of these pigmentations. Of course, if the variations are so unique or atypical, further investigations are recommended to rule out a frank pathological diagnosis. Another but relatively less common aspect of the oral cavity to show racial pigmentation is the tongue, especially the fungiform papillae in varying proportions as is evident in this individual. These are non-pigmented fungiforms with a pink coloration, whereas these black spots here are fungiform papillae with melanin pigmentation. In some instances, even the plica fimbriata on the ventral tank surface may show features of OPP in dark-skinned individuals, and here is one example of such cases to demonstrate this. Again, bilaterality and symmetry should suggest a physiologic phenomenon rather than frank pathology. This isn't always the case, but it's quite a good clue to differentiate between what is likely to be physiologic or normal variation versus a possible pathology. Anyways, how do we explain the physiology behind OPPs? Well, if you have been paying close attention within these few minutes of the class or so, you should straight up tell me that the pigment responsible for clinical appearance of OPP is melanin, and melanin is manufactured by cells resident within the oral epithelium called melanocytes or pigment cells. These cells are normally present within the basal layer of the stratified squamous epithelium. From your fundamental histology and embryology classes in dental school, you can recall that these melanocytes are derived from precursor melanoblasts, which in turn are derivatives of the multipotential neural crest cells. You should also recall that neural crest cells are a group of temporary embryonic cells that form only during early development in utero and migrate to various body locations to differentiate into a number of different anatomic tissues. I wouldn't want to deviate from today's topic to begin listing these progeny of neural crest cells, but for the purposes of this lecture, however, some neural crest cell derivatives become melanoblasts, which then become melanocytes. There are certain molecular factors responsible for this melanocytic differentiation and maturation. The two main ones are the Still factor and endothelin 3. Once differentiated, the melanocytes begin the process of melaninogenesis or melanogenesis or melanin production. These all mean the same thing. The process involves a series of steps beginning with the amino acid tyrosine under the influence of a melanocyte stimulating hormone. The resulting pigments are then packaged carefully into vesicles called melanosomes, which are then transported along cytoplasmic processes of the producing melanocytes and then secreted into the cytoplasm of adjacent keratinocytes. Essentially, the melanin pigments synthesized by melanocytes are distributed to neighboring keratinocytes by way of these poles of dendritic appendages, and each melanocyte supplies a group of keratinocytes, forming the so-called keratinocyte-melanocyte structural unit. This intimate melanocyte-keratinocyte relationship is essential for the intraepidermal melanin to be visible as a pigmentation or skin color we observe every day. Effectively, keratinocytes are required for the expression of melanin. Within the keratinocytes, melanin functions mainly to protect the DNA against reactive oxygen species, inflammatory injury, and harmful effects of ultraviolet radiation by forming a shield around the nucleus of that particular keratinocyte. By doing so, they prevent UV-induced mutations and strand breaks that would otherwise lead to acute sunburn or neoplastic changes. The pigments are, however, gradually broken down with time as the basal keratinocytes migrate to the superficial layers of the epithelium, but then the supplies are readily replenished by melanocytes within the structural unit. Now, some of you have in the past raised some questions about skin color and its variants, and so let's take a few minutes to discuss this. What you should note down is that normal skin color variations are not determined by the number of melanocytes, but rather by the amount of melanin synthesis and the distribution of melanosomes. Whereas light-skinned individuals have fewer melanosome production, dark-skinned persons have more melanosomes. Now, note that I mentioned melanosomes and not melanocytes. The number of melanocytes remains the same for any one person, just the melanosomic vesicles vary in number. The type of melanin within these melanosomes also influences the outcome of visible skin color. Eumelanin has more brownish black color, whilst pheomelanin imparts a reddish brown coloration, and a mixture of these two in varying proportions influence the final outcome of skin color. In relevance to this lecture, Physiologic pigmentation is also simply a result of increased melanin distribution and not from melanocyte hyperplasia or anything of the sort. The same is true for individuals who tan themselves under solar or non-solar UV light. When the result of pigmentation is caused, however, by increased number or proliferation of melanocytes, then that's a qualifier as a definitive pathological lesion which must be managed as such. These hypermelanocyte disorders or pathologies range from the benign nevus lesions to malignant melanomas, of which there are different forms. Destruction of melanocytes, on the other hand, results in vitiligo, whereas a reduced melanin synthesis or melanosome release will be the underlying explanation for albinism, and it's mostly congenital or genetic. We will have individual lessons on these other conditions basically moving forward in subsequent lectures. Now, let's list some physiological functions of melanin in the oral and facial regions. The first and most obvious is the determination of mucosal color, and depending on the intensity, it may in fact mask the detection of mild mucosal changes such as white keratotic lesions, red erythroplakic lesions, yellow lesions like Fordyce lesions, and many others. Melanin has antioxidant properties, and its synthesis may function to downregulate local inflammatory responses. It is capable of neutralizing reactive oxygen species generated by oral infections, pathogens, and chronic inflammatory diseases. Within the oral cavity, this function is probably more important in the surface mucosa rather than the circular or junctional mucosa because these other sites do not usually contain melanocytes within the epithelium. Fourthly, oral melanin possesses antibacterial characteristics by physically neutralizing bacterial peptides and toxic products. Also packaged together within the melanosome vesicles are lysosomal enzymes having bacterial degradative properties. So you could envision melanocytes as key cellular players in the innate defense against a variety of invading pathogens, especially bacteria and fungi. Finally, and especially important for the lip and surrounding extraoral cutaneous surfaces, melanin functions to shield us from the harmful effects of the different types of UV radiation, types A and B especially, and by doing so confers the benefits of both anti-oncogenicity and then anti-senility. Alright, based off of all these and everything we've discussed so far, we can appreciate why physiologic melanin pigmentation is not considered a pathological state, but rather it indeed could also provide health benefits and protection from various angles in a multitude of ways, and therefore almost always requires no therapeutic intervention. Individuals who lack the ability to produce sufficient levels of melanin usually tend to suffer from a variety of cutaneous and mucosal disorders, hypersensitivities, lip premalignancies, oral infections, and so on. Of course, extensive pigmentations that are unsightly because they show up in aesthetic zones may be of concern to the individual and may have to be dealt with, but overall, these benign pigmentary states, once confirmed, do not require any sort of treatment. Speaking of confirmation, there are a number of lookalike lesions that must be differentiated from physiologic pigmentation, especially those that take on atypical morphological characteristics. These lookalikes or differential diagnoses may include oral melanotic pigmentations in Addison's hypoadrenergic syndrome, spotted oral mucosal and labial pigmentations in Peutz-Jeghers syndrome. These dark colored spots in Peutz-Jeghers syndrome may also be observed in a periorbital, perinasal, or perianal location and may also occur on the palmar and plantar surfaces of the hands and feet respectively. The early stages of malignant melanomas may exhibit just a simple macular pigmented appearance and may therefore also mimic physiologic pigmentations. Note, however, that there are indeed some melanomas that occur without pigmentations, so-called amelanotic melanomas or non-pigmented melanomas. Anyways, other less sinister but still important differentials to consider will be amalgam tattoos, smoker's melanosis, and melanoic anthoma, but it could also include post-inflammatory melanosis or drug-induced pigmentation, especially following the use of medications such as antimalarials, certain antifungals, and antivirals, and even oral contraceptive pills. Sometimes submucosal bleeding or bruising may have a striking resemblance to oral melanotic pigmentations. However, a history of trauma will be apparent in such instances. Confirmation of all these disorders may require a laboratory workup, imaging, and histological assessments. Some of them, such as the melanoacanthoma, may even regress following incisional biopsy. So now, what do we do in terms of managing OPPs? Well, the management of OPPs is really quite simple because, as I alluded to previously, it requires doing nothing but only reassuring the patient and monitoring. If you must treat because of aesthetic concerns, then trying out laser therapy and cryotherapy may help, even though the pigmentations are likely to recur. Gingivectomy procedures may be tried for unsightly gingival pigmentations.